want to discuss that case. There is one patient, 22-year-old female with a history of a low-grade fever for 1 month. She was following OPD base, and only there is a problem with upper respiratory tract infection. After that, only antibiotic was given 2-3 times, but still she was not recovered. After 1 month, she was admitted with severe symptoms. Then she developed on investigation pancytopenia. Then the condition was worsening. All the labs, all the
So it was
measures, all the
just
investigations were.
Just to note down, she was a young lady, pregnant lady.
22-year-old female, yes, with low-grade fever only.
Low-grade fever, okay.
For 1 month. After that, only upper respiratory tract infection, treated by antibiotics 3-4 times in 1 month.
Actually, this is mainly related to medicine. Because they will be diagnosing, they will be doing some, because pancytopenia can be because of lymphoma.
But sir, all the investigation regarding lymphoma done, it was negative. Bone marrow biopsy done, it was all okay.
Okay, patient not
all
taking
the genetic testing. No, not any other medication rather than antibiotic. Then after 1 month, she developed dyspnea, desaturated, become on oxygen dependent for 2 liters, COVID test, all other tests negative. CT, HRCT is negative for pulmonary embolism. Then she become hypotensive, pancytopenia ongoing. Then she became admitted in the ICU. Then after 1 day, she become intubated on mechanical ventilator. And still chest X-ray was clear. After all the investigation, only one positive finding was that she was become blood is positive for Epstein-Barr virus.
Yes.
And they diagnose as HLH syndrome.
What is this HLH syndrome?
Sorry, I don't remember. HLH, leukocytohistocytosis. Some syndrome.
Anyways, remember one thing, anesthesia. That's why anesthesia should be separate from ICU. ICU is a totally different specialty than anesthesia. Okay, for us, this is related to, we are dealing with the emergencies, we are dealing with the electrolyte imbalance, homeostatic conditions, ventilation, inotrope, vasopressors, any unwanted event. But this is, I told you, listening to your history to start with, this is not related mainly to us, frankly speaking. Nobody will be asking you this question in the exam. Nobody will ask you
in that scenario. In that scenario, she was very become desaturated up to 80. Even on ventilator, she was saturation was only 82.
We never know. Because at that time, then you will be looking at VAP, then you will be looking at ARDS, things like that.
No, sir, it's very early. Even after intubation, the saturation was 84. Then we do proning and deproning, 16 hours, then 4 hours.
Embolic phenomena. Micro.
So routine CT done. It's all clear.
Routine CT,
but in the end,
routine CT will not pick it. For that, we need Sumera. What CT is needed for ruling out pulmonary embolism?
Sir, HRCT.
HRCT.
ATPA.
No.
Sir, वो जो scan करते हैं, like that scan.
HRCT and pulmonary angiography.
Yes, CT angiography.
Okay, so actually
CT angiography done, it was also negative.
Anyways, I'm sorry, I'm short of ideas for this thing, but actually remember one thing, as a practical, of course, in working in ICU, you can see these patients, but in exam, forget about it. This is not exam for anesthesia. They can, in anesthesia exam, this question will never be asked. Okay, so we will discuss.
It was basically, I think it was basically a viral infection leading to these all destruction, and plus infections also cause bone marrow suppression. So that could be the reason of pancytopenia.
Yes, unknown viral infection, because viral infection can cause such things. Okay, and they are usually not being explained. Which you are the disease which you are telling, how they, on the which basis they diagnose this that disease. Yes, Dr.
Sir, yes, sir, only on the basis of this blood investigation, they said Epstein-Barr virus is there. So there is HLH syndrome.
Anyways, maybe, I'm not sure. Anyways, so we will start magnesium. Magnesium, remember one thing, magnesium is very important to anesthetists. What are the different roles of magnesium in anesthesia and ICU care? Yes, Sumera.
Sir, we can use magnesium in patients of eclampsia.
Okay, PIH.
And PIH.
Then?
And even we can use in to prevent like a status asthmaticus.
Okay. Then?
And
ICP role.
Dr. Humera, she is exam candidate. She is my main target. Just let her speak. Yes.
sir, we can also.
Do we use it as analgesic?
Okay.
Do we use it as antiarrhythmic?
Yes, sir.
Do we use it antihypertensive?
Yes, sir.
Okay, so why you are not telling? Okay, so and very interesting role, because sometime if insulin resistance is there, hypomagnesemia is one of the cause. So when in control of diabetes, magnesium levels are also be targeted, because magnesium is important for protein synthesis, for fat synthesis, for ATP. Okay, so insulin is also a protein hormone. Okay, so it is not only for it is important for protein insulin synthesis, but also its effect. Okay, so if there is like, this is actually just today I read from somewhere about it. So this is something new for me, the relationship of magnesium for a number of things. In even in when there is asystole, on everything you are giving, and then you also give magnesium sulfate. Okay, so it has a number of roles, and as with any other thing, it is absorbed from GIT. Which part of GIT? Jejunum and ileum. Okay, so this is the place. So anything which is causing malabsorption will result in hypomagnesemia. Okay, so this is one thing. Then it is present mainly in bones. Okay, but it is not strictly controlled as calcium or phosphate. Its level is dependent on renal excretion. From renal, from where it is excreted through kidneys. It is its absorption occurs in thick ascending limb and distal convoluted tubules. Okay, so these are all actually they can ask you this question in MCQs as well, because if you are giving furosemide, it is also resulting in decreased magnesium levels. Okay, and of course, if there is signs of hypomagnesemia, it will be related to it may be cardiac effects, it may be neuromuscular effects. Okay, because magnesium is important for the relaxation of muscles. Okay, so whenever there is hypomagnesemia, there are cramps, there is spasms. Okay, there is ileus. So all effects will be there. So when we can replace it through oral, or we can replace through IV. Okay, so this is one thing. And for hypermagnesemia, in emergency, we have to give either calcium like gluconate or chloride, diuretics. Okay, or next step will be dialysis. Okay, so what will be the effect with anesthesia? Neuromuscular blocking agents effect will be prolonged because of it is antagonist, calcium antagonist. Okay, so this is the main thing. Of course, QT interval prolongation in hypomagnesemia. Okay, so it can lead to torsades, it can lead to VF. Okay, so this is just an overview of magnesium we should be knowing. It is as I told you that it is used as antihypertensive. It is used as a membrane stabilizing to prevent fits. It is being used as antihypertensive. It is being used to blunt the sympathetic response. So even there are studies on magnesium being used as analgesic. So it is part of multimodal analgesia protocols. Okay. So this is just an overview, and now we will just go to some text. Okay. So about half of the magnesium, it is mainly intracellular. Okay, just after potassium, and mainly in the muscles, bones. Okay, and both as ionized and unionized, or mainly you know that ionized fraction is physiologically active. Okay, so as I told you that it is related to ATP, and ATP is important for life. Like life is ATP. Okay, so when there is no ATP, there is no work functioning of sodium potassium ATPase pump, and actually cell lysis will occur because membrane potential will not be able to maintain. So that is the the main effect which is there. Okay, and magnesium and calcium has very complex relationship. It is antagonizing as well as, and sometimes when there is hypomagnesemia, it is also related to hypocalcemia. Okay, similarly,
Yes, acute shortage.
yes, acute shortage. Similarly, potassium is also related to magnesium. So and when whatever things I was just trying to see, the magnesium is least understood of iron. Okay, so some ion channels are still undiscovered, that how it is managed. But usually remember that if there is acute parathormone and aldosterone are affecting it. Yes, this thing I forgot to tell in the introduction. But usually magnesium is not as strictly controlled as calcium or sodium or potassium. So this is the bottom line. So this should be knowing about it. Okay. And as I told you, that it is involved in glucose utilization through this insulin protein synthesis. Okay, and it has direct effects on myocardium and vascular smooth muscles. Okay, so if there is increased levels more than the therapeutic levels, it will affect first skeletal muscles, then respiratory muscles, and then cardiac muscles. That's toxicity moves. Okay, and okay, so vascular smooth muscle effect is there, and blunts the response of vasoconstrictors. So it is, as I told you, that is membrane stabilizer. Okay, it decrease the sensitivity to the catecholamines and even release of histamine, and so this is a stabilizer. Okay, it antagonizes calcium ions at presynaptic junctions and can result in decreased release of acetylcholine. Okay, so when there is no acetylcholine, so there will be neuromuscular weakness. That's why magnesium levels, whenever patient is taking clinical like inference is that if you have a patient with the patient on magnesium, you should reduce the dose of neuromuscular blockers, and you should be doing the neuromuscular stimulation. Okay, so this is in the exam, Sumera, like whenever they are asking you this thing, you should be telling these things. Okay, and it also had some antiplatelet effect activity, so increased bleeding time when administered by intravenous infusion. Okay, magnesium deficiency is associated with platelet hyperactivity. Has shown to suppress epileptic foci and reversal of cerebral vasospasm. So it is being used like that. Okay. So as I told you that it is body stores circulating extracellular pool is they are then regulated by hormonal and metabolic effects of GIT absorption and renal excretion. So roughly you will find different values in different. So usually it is like millimole, then milliequivalent, then milligram per DL, and it's almost double. For remember that for sodium potassium, millimole and milliequivalent are the same. I don't know the reason. If anyone knows the reason, you are free to tell that why it is how we convert millimole into milligram. So I have no idea about it. I don't think so. This is a scope of for us. If someone knows it, you can share. Okay, and usually it is excreted through kidneys, and 1% of filtered appear in the urine. Majority is reabsorbed in the ascending limb of loop of Henle, and capable of reducing magnesium loss up to 5 millimole per day. This is, and as I told you, aldosterone increases renal excretion. So if there is anything which is decreasing aldosterone, will cause hypermagnesemia. So when there is Addison's disease, there is hypermagnesemia. Okay, and when there is hyperaldosteronism, there will be hypomagnesemia. So this is also you can. And parathyroid hormone, just like calcium, it increases the magnesium level in the blood by decreasing the renal excretion and gut absorption. So hypomagnesemia when it is less than 0.7. And as I told you that anything which is causing a deficiency in diet, malabsorption, or inappropriate IV infusion, if the patient is on dependent on that. Okay, renal loss, Bartter syndrome. If you remember, it is a disease affecting the mimicking the effect of furosemide. So it is so in that magnesium will be lost. Okay, hyperaldosteronism. Okay, GI tract, as I told you, primary hyperparathyroidism. This one I don't understand, because they have told that parathyroid hormone is increasing the, so I'm not sure how it is happening. Anyone knows about it? How primary hyperparathyroidism will result in hypomagnesemia? It should cause hypermagnesemia. No, they are putting it in redistribution. Okay. So the clinical features will be of hypomagnesemia, hypertension, angina, dysarrhythmia. As digoxin toxicity occur in hypokalemia, similarly digoxin toxicity will occur in hypomagnesemia. So remember this thing, okay? And there is myoclonus, stridor, dysphagia, tetanus, all the this spasm-like activity will be there. Okay, so psychiatric disturbances, convulsions, coma, and other electrolyte manifestation will be hypomagnesemia, hypoglycemia, and hypokalemia. Okay, so you should be knowing the drugs which are causing excessive loss. These are loop diuretics, alcohol, cyclosporin, some antibiotics, Bartter syndrome, as I told you. Okay, So the questions will be coming to you on the basis of these things: QT interval prolongation, okay, torsades, VF, okay. And again, just like hypocalcemia, same dystrostic sign and Trousseau sign will be there. Okay, so these are actually just hypermagnesemia. So hypermagnesemia causes will be, as I told you, that reverse of the things. So hypermagnesemia will be if there is a hypoaldosteronism, it will result in hypermagnesemia. Or anything when the GFR, for example, patient is in shock, hypotension, following rhabdomyolysis, or any cause of ARF, there may be hypermagnesemia. Okay, and these enemas and antacids also has magnesium. So inadvertently, if patient is taking these things, it will result in magnesium toxicity, or patient is taking for therapeutic and it is overdose and it is causing hypermagnesemia. So that's why it is very important to monitor. Sumaira, with relation to preeclampsia, if they ask you a question that you told that I will be giving magnesium, so how will you tell them that, how will you monitor the magnesium levels? What should be your answer?
Sir, we can assess clinically, and as well as we can go for magnesium levels like serum blood calcium levels as magnesium levels.
Anything else? You are missing a very important thing.
Sir,
Deep tendon reflexes, urine output.
Urine output. Okay.
So they are clinical signs, na? Like urine output to decrease tendon reflexes, any arrhythmias on ECG.
Yes, so you have to tell,
respiratory depression.
like you will tell that clinically with reference to urine output, because if urine output is not there, there will be chances, even if there is no clinical symptom appearing, if there is no urine output, you have to react, okay, because you will lead ending up. So most important thing is urine output. As we told that there is no other way magnesium can be excreted from the body. So urine output is very important, and then you can tell that we will observe through ECG or deep tendon reflexes. And another thing, respiratory insufficiency. Okay, like if patient is having hypoventilation or anything, you will be anticipating. Okay, so that is important, because whenever they are asking you this question, start with urine output. Okay, because urine output will lead to the other thing. If the urine output is decreased, then you are in like patient is on line to develop problems. Okay, so these are the same thing as a smooth muscle relaxant. In different books you will find different things. Even there is an international, I think, AAGBI protocol for it, but usually you will say that according to the situation we will load it, and then looking for the signs of toxicity, you will continue the infusion. Okay, and with reference to eclampsia, preeclampsia, till what time will you continue magnesium? Yes, Mera.
Sir, until patient is fit, free from last 24 hours, and
Postmortem. You will continue. You will not stop it till the baby is delivered, because till the baby is not delivered, placenta is not delivered, there are chances of still fits. Okay. So this is something important. So I think
even 24 to 48 hours, I guess, after the delivery.
24 to 48 hours. Yes, you are right. Actually, you know, it's easy to explain in Viva. It's very like you have to be pinpoint in MCQs. Okay. So okay, what other medications are also increasing the neuromuscular prolongation? What other medications concomitantly given can cause increased duration? aminoglycoside,
Aminoglycosides,
Lithium.
gentamicin.
Yes. Okay. So always tell about ECG, and as I told you, urine output. And what else? So you see, hyperventilation leading to a respiratory alkalosis should be avoided, as this will cause magnesium to shift intracellularly, thus depressing plasma magnesium concentration still further. So this is an important thing. Now, you will not cause hypomagnesemia, you will not cause alkalosis. Okay. Intubation, magnesium sulfate has been used to blunt suppress the responses to laryngoscopy, intubation, and extubation, as I told you. Okay. There are so many studies going on for use as analgesic. Okay. In cardiopulmonary bypass, partially common falling cardiopulmonary, they are you giving it as antiarrhythmic. Okay. And even it is not written here, maybe you will find here that it is also an refractive patient is not recovering. So magnesium is also given even in cardiac arrest and fatal arrhythmias. Okay. Epidural anesthesia, I have not seen about, I don't know about it, how to use it. In pheochromocytoma, it is also given as an adjunct. Okay. When will you give magnesium in asthma? Yes.
सर refractory asthma में देंगे जब
Very good. When you have exhausted the first line treatment, okay, then you will be giving it. So the same things. Any question? I think we have covered almost all the aspects. Okay. So just keep in your mind these electrolyte imbalance are very important. Okay, the same things they are written here. So yes, you see this one I was missed. It has tocolytic effect. Magnesium is also used as tocolytic. Okay. So that's how you should be scanning these articles. You will find 80% things same, but you will find something which you have missed, because I have missed this tocolytic effect. Okay. So any comments, Usman, anything? Sumaira, you should be knowing very well about these things. Okay.
Sir, one question which is very frequently asked: the levels and the levels of magnesium toxicity and their effect. Like
Yes,
at
so
what level the respiratory depression will come, at
as
what level the cardiac will come,
as
at
soon
what
as
level
you as soon as you said, so it is came. The answer is there immediately. 4 to 5 millimole for this muscle weakness, and then respiratory paralysis, and because these values are different in different units. So remember,
you should remember at least one in order to avoid confusion.
yes. Okay. So because millimole per liter is the SI unit, so it is better for you to, but in Pakistan usually we are looking at milligram per DL. So you should be knowing about it. Usually I think it is double is a milliequivalent, and double for milliequivalent is in milligram, if I'm not wrong, but I'm very bad in recalling the numbers and everything. Okay, so whenever there is hypermagnesemia, you will stop anything going, IV calcium gluconate, diuresis, if there is some renal function is intact, otherwise dialysis. Okay, so I think it's enough for today. I will try to have phosphate next time. Okay. So any questions, please? Okay. Thank you very much. Inshallah, we will meet again. Assalamu alaikum.